is my pleasure today to be part of the AWE Art of Innovation course 2023, and I am excited to be talking to you about the endoscopic management of GERD. These are my disclosures. So as we all know, GERD is a large chronic problem. If it's not clear by the numerous cartoons you can find on the subject, the data also tells us that it is a significant healthcare issue. About 1/4 of all Americans, or 81 million people, suffer from reflux disease. It's the #1 reason that patients will seek care from a gastroenterologist and is responsible for over 8 million visits a year and 134 million prescriptions for GERD medication. So we are all familiar with the dietary and lifestyle changes that are recommended for management of GERD, such as avoidance of trigger foods, which I've listed here on the left side of the screen, staying upright after eating, small meals, eating slowly, avoiding things like smoking and caffeine and alcohol intake, sleeping with wedge pillows on your left side, and of course, weight management and weight loss. But in the real world, it can sometimes be difficult to avoid all these types of food or have a less fast-paced lifestyle, especially in New York. And so sometimes, unfortunately, diet and lifestyle changes alone are just not effective for treatment of GERD symptoms. And for those who fail dietary and lifestyle changes, the next step is generally medical therapy, which consists primarily of the PPI class of medications. And PPIs are great medications. However, a percentage of patients will become refractory or intolerant of PPIs over time, and up to 50% of patients may lose their response to medical therapy over time. In addition, I like to tell my patients it's a new trendy thing in medicine recently to report on a potential side effect related to the PPI class of medications, and I listed a bunch of them there. And although many of these are from association studies and not proven cause and effect studies, what I generally say is where there's smoke, there's likely fire, and there is likely some harm to being on high doses of these medications for years and years. And for some patients, diet and lifestyle changes and PPIs are not enough, and they really want some kind of intervention or action for management of their symptoms. And it used to be that once you moved past lifestyle changes and medical therapy, really the only option was to then move on to the surgical interventions. But there were many patients that may have been suffering with symptoms, but chose not to undergo surgery due to concerns about the invasiveness of surgical interventions. And to put it another way, of the about 6.5, a little more million uncontrolled GERD sufferers, less than 30,000 elect to undergo surgery. And this is where endoscopic therapies can now really help to fill this treatment gap. So when we talk about endoscopic treatment options, the main ones that we'll discuss today are the transoral incisionless fundoplication, or TIF procedure, non-ablative radiofrequency, or STRETA, anti-reflux mucosectomy, or ARMS procedure, and the mucosal ablation procedures. So starting off with the TIF procedure, TIF stands for transoral incisionless fundoplication. This is a procedure that creates a 270-degree plication along the greater curvature towards the lesser curvature in the stomach and creates a 2 to 3 centimeter wrap valve. And when we're talking about the TIF procedure, as I mentioned, we want to capture and treat as many patients in this treatment gap as possible, but patient selection is also critical, because the worst thing is to put a patient through a procedure and relatively significant post-procedure recovery only to have it not be effective. So it's important to think about the inclusion and exclusion criteria for who would benefit from endoscopic therapy for GERD. And for the TIF procedure, patients need to have some sort of objective evidence of GERD, whether it's esophagitis, whether it's a pH study, whether it's just a response to PPI, and they must have a hiatal hernia that's less than 2 centimeters. So anyone that has a hiatal hernia greater than 2 centimeters would not benefit from the TIF procedure. It's feasible, but it won't be efficacious in the long run. Additionally, if there's the presence of severe esophagitis, that needs to be treated prior to undergoing therapy. And then, of course, anything that would prevent them from having endoscopy or for getting safely the device down into the stomach, such as strictures or large diverticulum, esophageal infections, or varices. And I just want to spend an extra minute talking about hiatal hernias because it's such a critical component of patient selection for these procedures. We know that endoscopic assessment of measuring a hiatal hernia during standard endoscopy can be somewhat unreliable, and therefore measuring the hiatal hernia both in forward view but also using the Hill system with the scope in the retroflex position is necessary prior to proceeding with endoscopic intervention. And here you can see the different Hill grade classifications, all the way from grade 1, where the flap is very tight against the scope, to grade 4, where it's completely effaced. And generally, Hill grade 1 and 2 patients are candidates for endoscopic therapy with the TIF procedure, but 3 and 4 likely will need surgical intervention for repair of their hiatal hernia in addition to a fundoplication. So this is what the device for the TIF procedure looks like. There's a physician interface, which is what the physician uses to control the device, and a patient interface, which is the part that is inside the stomach. And this is how the procedure is performed. It's done in a stepwise fashion, basically turning the GE junction into a clock, starting at the 11 o'clock position, then moving to the 1 o'clock position, then going to the 7 o'clock and the 5 o'clock position. And fasteners, which I'll go through in just a second, are deployed in each location in order to anchor and create the wrap. And generally, the 11 o'clock and the 1 o'clock positions is where the wrap is performed. This is where the tissue is grasped with a grasper. It's pulled between the jaws of the device and twisted towards the 12 o'clock. So that's clockwise from the 11 o'clock position and counterclockwise from the 1 o'clock position. And then that tissue is locked in place and the fasteners are deployed. And at the 7 o'clock and 5 o'clock positions, the goal is length more than wrapping. And here the tissue is grasped and pulled between the jaws, but pulled farther between the jaws to really create the length of the valve. These are the fasteners that I was mentioning. They are small plastic H-shaped devices. They are strong and they hold the tissue in place after deployment, but over time, actually, they become less important because they cause fibrosis, which is what keeps the wrap intact long term. And they are delivered via stylets during the procedure, 2 at a time. And generally, you're placing anywhere from 20 to 30 during each procedure. It's important that patients know before embarking on a TIF procedure what the post-procedure management is, because it can be a little bit intense. It's similar to the post-Nissen fundoplication management. And it's also important for the endoscopy suite to be prepared to do these procedures, as it does require some special preparations, including, of course, the device itself. And it's always good to have one extra on hand just in case there's any kind of technical failure, which is rare, but can happen. It does require 2 insufflation devices. Generally, patients need to be under general anesthesia with paralysis of the diaphragm to avoid inadvertent capturing of the diaphragm between the fasteners, and patients are generally positioned in the left lateral position. And post-procedure, it used to be that I would admit all my patients post-procedure. Now I would say the majority go home after being observed for a couple hours. Everybody goes home with antiemetics prescriptions and usually pain medication, which can be often managed with liquid Tylenol, but I do sometimes prescribe liquid Tylenol with codeine for those that have a little extra pain. They are on a strict 6-week diet, which is clear liquids for the first couple days, and then full liquids for up to 2 weeks after the procedure, and then slow advancement of foods back in over the next couple weeks. There are some exercise restrictions as well. I generally will continue patients on their dose of PPI until week 3 or so, and then start to wean off unless the patients have a history of Barrett's esophagus, in which I keep the PPI longer until I do a pH study to confirm successful acid control post-procedure. One of the nice things about the TIF procedure is that it really has excellent clinical data supporting its use. This is the TEMPO trial, which was a randomized multi-center trial of greater than 60 patients, randomized 2-to-1 to undergo TIF versus PPI alone. And the results showed that there was significantly higher elimination of symptoms in the TIF group. 90% of patients were able to come off their PPIs, and the TIF was equivalent to PPIs in terms of normalizing esophageal acid exposure. And when you look at data 1, 3, and 5 years later, there was continued improvement in GERD assessment tools. About 66% of patients were able to remain off their PPIs, and 80% showed persistent symptom improvement. Similarly, this is the RESPECT trial. This was also a randomized multi-center sham controlled study of 120 patients randomized again 2-to-1 to undergo TIF versus placebo, TIF plus placebo versus sham study plus PPI. And the sham procedure actually included an endoscopy with placement of a 60 French dilating catheter that was positioned across the GE junction for the same duration as the TIF procedure lasts, which is 60 French is about the diameter of the TIF procedure, so it's a quite impressive comparison group. And what this study found was that in the TIF group, they had less regurgitation, less heartburn, less time that the pH was less than 4 on pH studies, and lower overall Demeester scores. And in this study, patients were actually able to cross over from the sham group to the TIF group after 6 months. And what happened was continued improvement in GERD quality of life scores as patients crossed over. And important to note, there was no difference in adverse events between the two groups. This is a meta-analysis done a couple of years ago evaluating the different studies, and the conclusions showed that symptom response favored TIF over PPIs and sham procedure, that TIF was non-inferior in decreasing acid exposure compared to PPIs, and that TIF was better at reducing acid exposure compared to no PPI. And this is a nice slide because another question I get asked is, what about side effects? And I think this table nicely shows exactly the benefit of TIF, that you get the same efficacy as compared with surgical anti-reflux interventions, but what's striking is the difference in adverse events and long-term side effects, which clearly favors the TIF procedure. As I mentioned earlier, patients with a hiatal hernia greater than 2 centimeters or Hill grade of 3 or 4 are not candidates for the TIF procedure because it won't be effective without hiatal hernia repair at the same time. However, one of the newer indications for the TIF procedure is actually doing a combined procedure where the hiatal hernia is repaired laparoscopically first, and then the TIF is done afterwards instead of the surgical fundoplication. And studies have shown that there are similar results to doing everything surgically, except that when you do the surgical hernia repair and the endoscopic TIF procedure, you get less dysphagia and gas bloat afterwards. You have less laparoscopic dissection, mobilization of the stomach, and you get to create a 270-degree wrap with 20 plus applications or fasteners that are deployed versus 4 to 5 stitches with the surgical intervention. So moving on, I just want to talk about some of the other endoscopic options available. The next one is the non-ablative radiofrequency or STRETA procedure. This technology works by delivery of low power, low temperature radiofrequency ablation energy to the lower esophageal sphincter through retractable electrodes protruding from a catheter on a balloon that's expanded and embedded into the esophageal tissue. And this results in tissue remodeling and thickening of the musculature, which helps to restore the normal barrier to acid reflux. And the initial data looking at strata was quite promising, but it fell out of favor for a bit after this meta-analysis, which included only randomized controlled trials, really found no difference in the physiological parameters for GERD, including time of pH less than 4, ability to stop PPIs, and quality of life scores. Anti-reflux mucosectomy or ARMS procedure is gaining some popularity in the management of endoscopic management of reflux. The way this procedure works, you basically create a wound that will contract after healing, decreasing the width of the GE junction, rebuilding the mucosal flap valve, and recreating a more robust angle of His. And the way it works is usually it's done using EMR technique, including band ligation, or sometimes ESD technique, where about 1 centimeter above the GE junction to 2 centimeters into the gastric mucosa, you are performing EMR or ESD. And then in some cases, actually, the bands are not resected, but actually left in place and fall off on their own. And as this heals, as I said, it contracts and gives you the desired effects. And it's usually performed 3/4 of the way around the circumference, or sometimes if there's a concurrent motility disorder, it can be done only halfway around the circumference. There's limited data looking at this procedure, still relatively new. This is one study of 19 patients where about 68% were able to discontinue their PPI after therapy, and there was significant improvement in the GERD quality of life scores at 6 months. However, there were some significant adverse events seen in this study, and some of the failures did require additional anti-reflux surgery post-procedure. This is another study, a little bit bigger, 33 patients, where, again, quality of life scores significantly improved post-procedure, and Demeester scores significantly improved post-procedure. So certainly the jury's still a little bit out, but early data looks certainly promising. And one nice part of this procedure is that it actually is repeatable, can be done multiple times. It's also relatively quick and technically non-complex procedure, so maybe an excellent option for certain patients. And lastly, I just want to talk about briefly the mucosal ablation procedures. There are several different types, all of which I've listed here, and they all basically involve creating a wound, again, around the GE junction in the retroflex position, and they differ by how that's created, whether it's by APC and suturing, whether it's by ESD around the area, or even hybrid APC around the GE junction, generally done in a butterfly shape like this. And similar to the ARMS procedure, the thought is as this wound heals, and it will contract and restore the anti-reflux barrier and help with management of symptoms. So in conclusion, PPIs are efficacious, but they're not adequate or safe for everyone. Traditional surgical intervention is efficacious, but is a more invasive option, and certain patients may not be willing to undergo there, and so millions of Americans are left in between, and this is where endoscopic therapies can fill that treatment gap. However, the decision of which intervention should be used must be individualized based on patient factors. You have the TIF procedure, which creates a great anti-reflux mechanism and has better data supporting its use than some of the other endoscopic options. And it may be ideal for patients interested in a less invasive procedure than surgery, or who are high risk for post-procedure dysphagia, but it cannot be used in altered anatomy or in patients with large hiatal hernias. The mucosal resection or ablation procedures can be useful in patients that do have altered anatomy who are not suitable for fundoplication, or when procedural devices are not available or cost of the TIF procedure is prohibitive. However, the data is limited really to single center studies without really long-term follow-up evaluating efficacy and durability. And then you have the strata, which may have a little bit suboptimal efficacy when compared to other endoscopic procedures, but may be useful in patients with altered anatomy. And I will stop there. Thank you so much for your attention.